Hi, hello friends. So, this is part 2 of systemic changes in pregnancies. So, here I'll be talking about the exocrine as well as the urinary tract changes that is occurring during pregnancies. And this is a very important one because we are going to cover two important topics in it. So, first, let's see about the exocrine system. So exocrine system, if you see in pregnancy, a new organ called as placenta is developed, and which is responsible for few enzyme and hormones secretions, as well as the normal hormones within our body is also undergoing lots of changes. So in that, first let's see about the two main hormones which is very different, that is human chorionic gonadotropin as well as human chorionic somatoammonotropin. So this human chorionic gonadotropin is a glycoprotein with the highest carbohydrate in a hormone in the entire body, and it is having two subtypes like alpha and beta. Alpha is common for every hormones like FSH, LH, and TSH, everything, whereas this beta is very different actually, and it is increased and decreased in few conditions, like it is increased in Down syndromes, heredity for moles, and then multiple pregnancies, whereas it is decreased in HCG like ectopic pregnancies and threatened abortions. And if you see HCG actually its main function is to maintain the corpus luteum of the pregnancy still the 26th day of pregnancies. Like I can label it you, HCG main function is to maintain the corpus luteum of pregnancy till about 68 weeks of days, because till then corpus luteum is what predominantly producing progesterone. Later on, this placenta can itself produce progesterone from the corticosteroids. So this is what is the function of the HCG, and HCG also stimulate the fetal testicular testosterone secretion to promote sexual differentiation. Therefore, that also it is important. And for thyroid gland also, for maternal thyroid gland is stimulated by this HCG. So it does three things, guys. One is maternal thyroid gland is stimulated, and testicular testosterone secretion is also stimulated, fetal testicular, and it maintains the corpus luteum level. And next, if you see this human placental lactogen or human chorionic somatoamniotrophins, which is actually very similar and structurally similar to human growth hormone as human prolactin, and it is a polypeptide. And when you see it, it is actually both this HCG as well as HCS, both are secreted from the syncytial trophoblast, and it will be very low in amount in early pregnancies, and during day pregnancy it will reach about 5 to 15 micrograms per ml at terms. And if you see during the delivery, during the period of time term, it will be the hormone which will be greater in production than other HCGs and all, and you can see it in the amniotic fluid level itself. And then if you see estrogen, normally during pregnancy, before normally without, when a woman is not pregnant, the estrogen is secreted from where? It is secreted from the ovary. But whereas once a woman gets pregnant, it is the placenta which produces the estrogens. Okay, and the estrogen that is produced in our body is predominantly estriol. Okay, so normally if you see the fetal liver is there, right? So so not fetal liver, adrenal of the child will have a DHEA, that is dehydroepiandrosterone. So this androsterone sulfate which is secreted by adrenal is hydroxylated in the fetal liver to 16 hydroxy dehydroepiandrosterone sulfate. As in placenta, it lacks 16 hydroxylase. It is not it is not sulfated. Instead it is getting desulfated and aromatized in the placenta to form estriol, which is actually 90% of cases it is placental estriol is the estrogen that is produced. And if you see the maternal pituitary has a little role in influencing of the estrogen, like FSH and LH has very minor role in estrogen synthesis, whereas it is main the placenta is responsible for its secretions. And next, if you see progesterone, and the progesterone during till 60 days, it is the corpus luteum which maintains this progesterone level. Later on, after 68 days, it is this placenta, with the help of the corticosteroids, it will start to secrete this progesterone. Okay guys, and the main function is like endometrial implantation, viability of the blastocyst, then it reduces the excitability of the uterine musculature, causes smooth muscle relaxation. We know a lot of things related to smooth muscle relaxation, then development of alveolus and lobules of the breast. So this is the most important thing. So we have covered HCG, estrogen, progesterone, and human placental lactogens, and androgen also. We know that testosterone and androtestosterones are actually converted to estradiol by the placenta, okay, which is in the maternal plasma. Estrogen and androstenedione are converted to estradiols in the placenta. And if you see this human placental lactogen, which causes lipolysis and inhibits gluconeogenesis, so it increases the maternal level of it leads to increasing the maternal level of insulin, and it may contribute to some anabolic effect of the mother and the liver. Like anabolic effect is what we learned is like mother stores this lipids, and this lipids are broken down and stored in the form of free fatty acids, and these free fatty acids, when the child is in less food or less amount, this lipid free fatty acids are used as their energy. So that is what it does. Human placental lactogen, it causes lipolysis. Lipids are broken down to the free fatty acids. So that is what it does. And the remaining, we have prostaglandin. It is a 20 carbon unsaturated fatty acid, and it is of three types: A2, E and F2, of which the later two is very important. I think E and F2 is very important. Prostaglandin, its high concentrations are found in the deciduea myometrium during delivery, and there is a reason to believe that this is the mechanism by which the product of conception is actually released out. That's why during delivery we give prostacyclin. Okay guys, next prostaglandin. Next we have pituitary hormones. We have FSH, LH, but these are very low amount. But FSH is predominantly suppressed in a greater it's not FSH. LH is suppressed in a greater amount than LH. And adrenocorticotrophin hormones like corticosteroid, it is predominantly produced in placenta, and this process is getting converted into progesterone actually. And melanocyte stimulating hormone, it is responsible for some skin pigmentation in the body, like alveolar pigmentation, and darkening of the linea alba, and mask like pigmentation of the faces and all. Hormones like vasopressin and oxytocin, which is produced from the posterior pituitary gland, they are of very lower sensitivity in the initial period of time, but at the end of the delivery they are of high sensitivity, because they are responsible for ejections of milk as well as for the uterine contractions. Vasopressin, and it is also one of an antidiuretic hormone guys. So corticosteroids, as we know, it is reproduced in the placenta, it is converted into progesterone. And aldosterone, as we all know, renin, along with maternal renin, there is stimulation of the renin angiotensin mechanism. So therefore the aldosterone is increased in secretion, and increase in secretions. Then thyroid hormone, if you see, thyroid binding globulins like placenta produce thyroid stimulating factors. This cause a rate of oxygenation is increased, so that there is increase in BMR. Insulin, as we all know, there is actually anti-insulin environment happening because of because of this human placental hormones and those hormones, the human placental hormones and rise level of corticols are responsible insulin resistant state. That is what important. Renin, as I said you, that is actually maternal kidney will always produce this renin due to increased vascular cardiac output and all. It is increased, no? So because of which for sure renin angiotensin system is activated, guys. So this is about the hormones, and later on let's see about the urinary tract system. So as I told you, the in urinary tract there is a lot of changes happening in the kidney size will be increased because of high output, cardiac output. There is the renal pelvic is also dilated, and there is elongation of the urethra. There are two reasons because of which there is lot of changes happening in kidney. One is the progesterone, which is responsible for initially to cause smooth muscle relaxation and lack of tone and all, and next is compression of the urethra by the enlarging urethra. So these are causing lots of changes in the kidney. And ureter is actually right ureter shows greater alteration due to this dextrorotation of the uterus, which is due to the left sigmoid, and there is urinary stasis in the dilated ureter that predisposed to urinary tract infections, as well as the right ovarian vein complexity. Dilated right ovarian vein complexity is also causing right ureter to have lot of elongation as well as dilatations. And then renal function, GFR is for sure increased by 50% because cardiac output is increasing. Then if you see renal plasma flow increases by 75%. And if you see for a pregnant woman to see is her renal function normal, we see creatinine clearance. And we all know amino acids and vitamins or water soluble vitamins are lost in urine of a pregnant woman in a greater amount. Therefore there is, which tells us that there is increased GFR, and glycosuria is very common. But then if it is in a persistent time, we should consult a doctor. And changes in bladder due to increasing in the size of the uterus, there is compression happening. On the 4th month onwards, the bladder shows hyperplasia of the muscle and connected tissue due to prostaglandin. Trichome is elevated, and there is marked whitening and deepening of the trichome by the end of the pregnancies. And this results in an base of the bladder becoming more concave and a change for its vaginal convexity. The pregnant woman will always have a complaint of increased frequency of urination. That is due to in the early weeks of pregnancy due to pressure exerted by the enlarging uterus on the bladder. And the nearing term, the fetal head usually engages into the pelvic so that there is no much complaint. And this one is about the urinary tract. Then skeletal system, as we all know, when a woman she gets pregnant, the postural changes are occurring, and there is increasing in lordosis and the lordosis, and she will have a lot of back pain and all. And abdominal pain, you have a stria gravidarum, stretch mark, and pigmentation, as I told you, cholasma and those vascular angiotomas, spider navi, palmar erythema are commonly seen in pregnancies. So this is not much important. Just remember about the urinary as well as the exocrine. Exocrine, if you want, you can refer it in marrow also. Marrow also, it is very useful. Okay guys, thank you for watching. I have completed this chapter.